I would like to first check with our panelists if they are up for a few questions, or should we call it a day?
No.
Are the panelists okay? Yeah.
Is there any questions I can take?
Right. So there are a lot of questions are coming, which I have kind of filtered it out also. So I'll start with the first question. This is for, I will direct some questions, but the other panelists also are free to join in and give their inputs as well. So the first question is for Dr. Aisha. Since Mucor invades the vessels and we don't have a biomarker, we have an indirect biomarker in the form of galactomannan and beta-D-glucon. So is there any role of D-dimer in prognosticating or pre-op risk assessment of Mucor patients?
So honestly, I haven't really read anything in particular on D-dimer, but over the past couple of months with the COVID pandemic, I've come to understand that D-dimer is perhaps the most non-specific marker of inflammation or thrombosis, which we're seeing positive in a host of other things as well. So we're seeing elevated D-dimers in patients who come in, well, that's something that's common, in patients who come in post-COVID with absolutely no other symptoms and developing, patients who've recovered who continue to have rising D-dimers. We're seeing elevated D-dimers in a host of other conditions because laboratories now have included D-dimer into a fever panel. So I've seen patients with malaria and high D-dimers, dengue and high D-dimers. Really don't know how to interpret this at all. And I've also had patients come in with post-COVID mucormycosis, again, as D-dimers done just as part of a regular lab panel with raised D-dimers, and we don't know how to interpret this. So it's an interesting question, but given the non-specificity of the marker, I really don't know how to, we need to sort of look into it further. I'm sorry, I don't have a direct reply.
Anybody else has anything to add to that? The role of D-dimer as a indirect biomarker, or there is a lot of fear psychosis in the minds of the patients, and we have always been asked, is there a blood test to kind of pick it up early and things like that. Dr. Aisha, is there an inoculation period of Mucor? Like we have started seeing patients even in immunocompetent patients, young patients. So what is the risk period for a patient who has suffered COVID? How long he should be vigilant and monitor himself to from the risk of getting mucormycosis?
That's a tough question, and we'll only know the answer as time goes on. But when you look at the pathophysiology of mucormycosis, we've had cases of, it has been reported that there have been cases of mucormycosis when once the inciting factor has been removed, the predisposing factor has been taken care of, the mucormycosis has actually been able to look after itself or self-resolve without any treatment or intervention. Of course, these are outliers and few and far between, but that goes back to the pathophysiology of Mucor being able to envelope itself into granulomas and form quiet latent pockets of infection at various sites. So this is not something that's commonly known or understood, but it can be subacute. It can remain sort of dormant in granulomas for time. And I've actually seen in the pre-COVID era, patients with hematological malignancies, especially this one patient who presented with disseminated Mucor, who we salvaged. And he came back after about 4 years with a relapsed leukemia and underwent reinduction chemo at that time. Fortunately, we weren't called in to sort of restart mold active prophylaxis, and he developed a relapse of the same strain, same species of Mucor, giving us to understand that perhaps they do remain as latent foci and can sort of activate at times of reduced immunity. So very difficult to say how long one needs to be vigilant, But by and large, what we've seen right now is up to 2 to 3 months, and as early as 8 days after COVID has been diagnosed.
Okay.
I think even in our series, it was 1 week was the earliest and 2 months was the latest.
1 week and 2 months. Okay. Hetal, you said a lot of young patients have been affected with Mucor. What has been the youngest? Have you seen any pediatric post-COVID-19 patient?
No. I have seen a juvenile diabetic pediatric mucormycosis.
Okay.
Not
Gaurav,
COVID.
have you seen any?
I haven't seen any pediatric cases so far, but in Karnataka, we've had 2 cases of pediatric being reported, especially in North Karnataka. That was one was 16-year-old and one was 11-year-old.
Okay.
There are presently 2 patients admitted in our government hospital. So I think one is 13 and another is 11 years old. But my youngest patient has been 21 years.
Okay. So it is not sparing the pediatric age group as well. Dr. Raguraj, have you seen isolated cases of orbital involvement without nose, paranasal, cerebral involvement?
No, I mean, we have not seen a single case of isolated orbital involvement without paranasal, but we are seeing increased incidence of fungal endogenous endophthalmitis, and those are actually we are seeing the primaries in the lungs. So aspergillosis and candida, we are seeing a lot more endogenous endophthalmitis, which we would not see otherwise. So we've had increased incidence of endophthalmitis, but that does not. I mean, we've not had a mucormycosis, which is just orbital involvement.
Okay. Now this question is open to all. We have diagnosed a case of mucormycosis clinically, or depending upon the clinical and radiological pictures, and we have sent the tissue for smear, stain, culture, as well as histopathology. But often the cultures are negative and we don't get fungus. So how do we explain this scenario?
I can take that to begin with.
Yes.
Mucormycosis is known to be very difficult to culture because the fungal hyphae are extremely fragile. They're very susceptible to homogenization, which is done in most laboratories. And even if you don't do that and you sort of take care to cut the sort of, hyphae and everything, it's still very difficult to culture eventually. To see on smear, you can use different techniques. Even a few doses of antifungal, if given earlier, do hamper the growth or the yield of fungus on culture, and we have seen that as well. And a lot of the patients who do come to us have received some doses of amphotericin B, whether in a suboptimal dose or have been started on oral azoles, mold-active azoles before coming to us. So both these would be the most important reasons. And then, of course, you'd need a tertiary referral laboratory which has the expertise to detect and correctly identify and grow these fungi in suitable conditions. Again, you can grow them at 2 temperatures, 30 and 37 degrees C, and that increases the yield of the fungal culture. So these are various microbiological techniques that could help.
Okay. Anybody else wants to add to that? How soon should this tissue, suspected tissue, sent to the lab? And
Do a frozen section on this tissue. As soon as we take the biopsy, the first thing we do is once we open up the sinus, we just take a biopsy and send it for frozen. And on frozen, our team tells us whether or not it is mucor. And then we sort of proceed with the rest of the surgery. We found even mixed growth now. In one patient, we had all 3, mucormycosis, aspergillus, and candida as well. And most of the second set of patients we have is with mucormycosis and aspergillus is sort of along with it is what we're seeing these days.
right, but most public hospitals might not have that luxury of frozen sections where the numbers are overwhelming. or sometimes even the frozen sections are not very conclusive.
Yeah, we did have that in about 2 patients of ours, followed up with a paraffin wax block and fungal, special fungal stains as well. So to answer your question, I think in that case, what the surgeon should take care is that it's also important how the specimen is handled. So when the surgeon is taking it out, it is better to always curate it out rather than take a forceps and sort of squeeze the tissue out, like Dr. Aisha already mentioned in the in her talk. And secondly, it should be stored in saline rather than some people just put it in formalin, which makes it much more difficult for the pathologist or the microbiologist to study the specimen. So once that is done, I think up to 24 hours, it can be stored in saline and then transported to the lab. That is what our pathologist has told us.
So the handling of specimen and transportation is also equally important rather than just yielding the specimen. Hetal, how do you do surveillance of these patients, your surgery patients? How do you do post-op surveillance? Radiologically, check endoscopies? Do you use any inflammatory markers?
They are usually more dependent on diagnostic endoscopy. It is only when the
Hetal, your voice is breaking. We can't hear you clearly.
It is mainly because all these patients, we are dependent on endoscopy. It's only when we are discharging them, we are trying to do a endoscopy, the scans.
Okay. Anybody wants to add to that?
Yeah, we are not doing imaging unless anything clinically changes. We are waiting. We are doing a regular nasal toilet, and ENT team is doing it. And if there is any orbital involvement, at the earliest sign of orbital involvement, we do a repeat imaging. If there was no orbital involvement earlier, so we do it early so that we can intervene early. That, I think those are the only things I can add to that.
Does serial leveling of CRP and ESR give us an idea that the patient is getting free of disease, nearing to the normal levels, CRP and ESR level? A lot of
Actually,
papers.
it's very inconsistent. We are seeing all kinds of things. CRP also we are seeing. I mean, we are monitoring the CRP as well, but it's not been very consistent. In some patients, it is normal on presentation also. So not necessary. I don't think it is a consistent way to prognosticate or see where the patient is. I mean, whether the patient is improving or not. But I mean, any other? At least our personal experience is that CRP or ESR has not been a consistent marker for the level of mucormycosis in the patient.
So how do you determine the end point of your treatment? Is it just the resolution of clinical signs and symptoms? Is it the radiological imaging, or it is your no recurrence or new well healing areas on nasal endoscopies?
I think we have to take all of them. So patient should not have any symptoms, at least for about 3 months of follow-up. Second thing is, when you repeat your serial MRI with gadolinium, you should not find any foci or hotspots. If there are any areas of suspicion, whether it is mucus or whether it is clot, blood clot, whatever it is, or if there is any area where you feel that the vascularity is even mildly compromised, take a biopsy and make sure that there is no mucor there. So if this is happening for about 3 months, then you can sort of cut down on your follow-ups. But what I tell my patients is that for the first 2 years, I would still like to see you at least every 6 months, because I want to know that their blood sugars are under control and to make sure that they are not having a recurrence of the disease as such.
Okay. Dr. Aisha, do you want to add something to that?
Yeah, so I'll go back to the point about CRP. Again, CRPs earlier on in the disease course are very, especially while the patient is hospitalized, are very difficult to judge because there will be sort of transient rises in CRPs with every sort of repeated surgical debridement or whatever. So CRPs might be useful adjunct once the patient is discharged and you're following up on on maintenance therapy, if I can say that. Apart from that, I would sort of agree with Dr. Gaurav here that it would have to be a conjunction of all things, clinico-radiological, as well as the check sort of endoscopies that are done to see that there isn't any disease recurrence. More importantly, I would like to actually ask the panelists that with our first wave cases that are coming back to us, we are seeing that they're clinically improving, that there is no, as you're saying, MRI showing new radiological hotspots or whatever, but and despite being on treatment, on optimum treatment, despite having received a full course of amphotericin B because it was available during the first wave, we're still seeing progressive destruction of the bones of the face. Right? Despite everything else having quietened down, the eye having quietened down in most cases, patients improving symptomatically, good glycemic control, but just marked ongoing sclerosis and destruction of the facial bones, especially the maxilla, the zygoma. Are any of you seeing this, and how do you sort of respond to this? What do you do?
So I think I feel it is an initial destruction itself, which was at that point of time it got controlled because of the amphotericin going on and all. So it may not be progressive because of that. So after we have stopped the treatment, it is still that indolent form is still present, and it just locally it's locally destroying the bone as the patient, because there's not much blood supply to that area. So that could be the reason why we are seeing those post mucormycosis sequelae.
So they're
So I
just
think
evolving changes as
probably
evolving radiological changes.
vascularity is very compromised in those areas already, and even though they may not have like active disease as such, but the sclerotic changes might be because of the vascularity of the bone.
I think it's mostly the avascular necrosis, which was sort of in the initial stages during surgery. And maybe it was probably the surgeon decided to salvage the organ rather than remove it altogether. And even I've done that in many cases. And in fact, of all the cases that I've salvaged, I had to go back and remove that bone only in one patient because there was significant involvement of that bone. I think it makes a lot of sense to try to salvage because you can always go back and do it. But if that bone has a chance to make it, then why unnecessarily remove it is what I think.
Right. Now, the most hot question of the current time, how are you guys managing the amphotericin crisis, and how are you procuring amphotericin for your patients?
It's $1 billion question.
It's $1 million question.
Yeah. So I want to get a sense of both the public and the private hospital, how they're managing their patients.
We are struggling, and basically initially I think 14th of May itself, all our hospital stocks got over, and from that time it has been a upward challenge with the government, with the situation. The patients are really struggling. We've managed to salvage some of almost a week or so. We did not have even one vial of amphotericin in the whole hospital. So we managed to salvage many patients with isavuconazole. What we found was that isavuconazole, at least if it doesn't, it actually at least stabilizes the disease, if not completely gets ahead of the disease. But we have been quite disappointed with the posaconazole as such. IV isavuconazole, I mean, there's no study as such done, but from our experience, we feel IV isavuconazole as at least it can be used as a substitute for amphotericin till our stocks are still very less.
Dr. Hital?
Extremely depressing because we don't have any other source, but luckily KEM distributes all over, so we get little better coverage than the other, but still it is very less as compared to the need.
Okay.
Extremely helpless. You cannot do anything and nothing else works.
Dr. Gaurav?
I've done a lot of things. I don't know if I should tell this on air, but I went to the center.
Yeah, I may run into trouble those things you have told me.
So we checked the central registry of all companies where all the drugs are present which have not been used. So we found some stocks in Assam, Tripura, Mizoram, which we airlifted. For one patient, we got an international import license. We picked up the drug from Sri Lanka and Nepal as well. I got a friend of mine to apply for a license. He owns a pharmaceutical company. So he applied for a license to produce amphotericin B. This was about 5 weeks back, and yesterday he delivered 1,000 vials. We've done lots of things, but our main goal was we don't want to leave our patients hanging there, by a thread of hopelessness. We didn't want to be even negligent towards our duties and responsibilities for our patients. So we've done a lot of things to sort of get the drug for them. We've not left any stone unturned. That I think I'll just leave it at that. Some of the things we've done are even out of our, profile or job description that we were supposed to do, but we've done it to make the best of it. And like Raghurat said, there was a certain time when even we didn't have amphotericin, in spite of all this, because at the time when I had almost 54 patients in my ward, and each one requires 7 vials of liposomal and or at least 2 vials of plain ampho. So I think for about 7 or 8 days, even we didn't have ampho, and that was the time when isavuconazole sort of helped us manage these patients. To top it, what we did was we created a separate debridement team. So every day there's one OT which operates and one OT which debrides. So with debridement in the sense that you just under local anesthetic clean the whole cavity and flush with peroxide to sort of make sure that the disease is still well under control. So this way we sort of try to manage and salvage most of our patients.
And also because we are being a little bit more aggressive in the last couple of weeks where there's severe shortage. We're being aggressive early in the disease. Earlier we had some time to think about whether to wait and watch how the antifungals are working. But right now we are actually being a little bit more aggressive. But what we are seeing is that the ones we have been aggressive early and we've debrided more of the disease tissue, devitalized tissue, they are doing a lot better once the amphotericin has started, the flow has started. It's getting better. The last 1 week is getting better, but it's not best. But hopefully in a couple of weeks, if everything goes well, we should have better flow of the amphotericin B.
I think Dr. Ajay, if you remember watching that video of mine where you saw that the IMAX is actually looking pretty much normal. Any person would have just left it as it is. But taking the trouble to trace it back and segmentally resect it and find out where the blood flow starts. So that because see, unless there is blood flow, no matter what you push through the veins, it's not going to come till here. And the other problem is if you have a high fungal volume in the proximal part of the vessel, it is just going to keep going on, invading the rest of the vessel as well. So what you want to do is do your best. So like Dr. Raghurat said, because of this phase, it has sort of taught us that you need to be a little more aggressive in your management, even during the in the operating room as well, because you just want to help your infectious disease colleagues' life easier. And at the end of the day, it's not about blaming who didn't do their job, but if you work as a team and you make sure that you do your job correctly in the OR, then your infectious disease person's job becomes a lot more easier in managing these patients.
So if you on scan, if you see normal looking retromaxillary area, but if your sphenopalatine is thrombosed, so you're saying he go one level ahead and look in for the hidden fungus.
It is like doing a neck dissection. If your level 2 is involved, then you have to go to level 3. So same thing you do here as well. If your sphenopalatine is involved, trace it back and see where it is extending up to. And you'll be surprised in most of these cases, actually, there is involvement is there. So what I always do is actually right now what I'm doing is for my research purpose is I cut part of the vessel if the sphenopalatine is involved, when I trace it back, I cut and I find that there is already microthrombi in a normally appearing vessel also. So if you are relying on a drug like posaconazole, which has extremely erratic absorption, you can't take the chance, because this microthrombus takes 48 to 72 hours to completely clog the vessel off. So there is no point in leaving that behind unless you have full dose liposomal amphobi, which is approximately 6 milligrams per kg body weight, which not everybody is getting now. Most of the patients are coming with only 3 or 4 vials, which is not of questionable benefit in these patients.
Right. Hetal,
Yeah.
do you do a Denkers? Do you do a Cardwell luck? Or you remove the inferior turbinate if you have to handle the
We have
anti-wall?
tried everything, and probably the patients who come to tertiary care centers are from a lower socioeconomical class with lower immunity, but we have seen that whatever you do is not enough. Whatever you do is not enough. Initially, we were very aggressive endoscopically, then we even tried adding the external, but it doesn't help the patient.
Okay. So my point was...
And believe me, it is far more aggressive than the mucors which we have seen in the past. Post-COVID mucors have got a lot of extensive, and it is very aggressive. Imagine none in 25 years I've seen, except those who were HIV, to involve the cranial cavity like this. So it is so aggressive that it has almost involved half of brains. So what are you going to do? How much do you going to debride? You think are you going to be able to debride the brain? No. So whatever you do is not going to be enough.
Yeah.
It is, in the end, it is a medical disease. It's not a surgical disease. So
yeah, if you have picked up those who are very early, it is very, hopefully we should do better than all these cases.
Dr. Raguraj, one counter against TRAM is if you're giving amphotericin systemically, then how do you know whether your local amphotericin injection is working, or it is the systemic one that is working for you?
Yeah, I completely agree with that. Actually, I don't. Even the doubtful value, we have reduced the number of number of cases.
Right.
That we are giving.
Aisha, is there any role of vaccination? Like only Gaurav mentioned in his talk, he had statistics of patients who were vaccinated and who were not vaccinated. So does it offer some protection against Mucor, indirectly, directly, whatever? Or should we be eliciting this history and trying?
Sorry, I lost you in bits over there, but what I do understand is whether you think vaccination would make any difference to the cause of or the probability of developing Mucor. Of course, we have no evidence for this, and whatever I say would be pure speculation. But given that we have seen Mucor in, I think Dr. Hegde showed us a case where you had a patient with asymptomatic Mucor or asymptomatic COVID only picked up on an antibody test. We've also had cases like this. We've had patients with mild COVID treated at home, practically asymptomatic. So I don't see how vaccination would then, have an impact on this, apart from the fact that it should hopefully bring down the total denominator of affected cases with COVID. But those infected, I don't see how vaccination might change the course of things. If I could just come in here for 1 second and talk about the other two azoles, which were discussed a little earlier. In the pre-COVID era, we did have patients who for some reason could not receive amphotericin B, who, with pulmonary mucormycosis in whom we couldn't debride effectively when they had bilateral lesions. In other cases of Mucor where it was difficult to reach spaces of sites of infection, and we have gotten away in the past, even with extremely poor bioavailability of liquid posaconazole before the tablets were available, before isavuconazole was available. Of course, again, these are just stray anecdotal cases. But even now, we do the serum posaconazole levels. And with the earlier liquid formulation, we used to really struggle to achieve levels. But the current tablet that we have, the DR tablet that we have at the moment, has shown extremely promising sort of results in terms of the levels achieved. We've achieved levels very easily, consistent levels, and we've seen rather good results in patients in whom we haven't been able to procure amphotericin B4. Of course, it's too early to say during this phase. We'll have to see how time goes on. But in our first wave patients who were then followed up with posaconazole or isavuconazole, again, very promising, but not much data. And whatever it's based on, the vital study is a very small study, retrospective, observational, nothing to really go by. But I wouldn't completely sort of push posaconazole out of the arena, especially if you have the means to do drug levels, because we're achieving drug levels with the drug. It's a cheaper alternative and it's working well for us.
Dr. Raghuraj, you mentioned there was no PL, probably central retinal artery occlusion or ophthalmic artery occlusion, and you've decided not to exenterate the eye. So wouldn't it be like leaving the disease in the eye, which will later on kind of blow up the eye?
No, I mean, it's a vascular cause. Usually there is no disease in the eye. It's basically the vessel.
So there is no thrombus. There is no thrombus there.
There is a thrombus. There might be a thrombus in the central retinal artery or the ophthalmic artery, but you can't chase that one thrombus and you have to remove the whole eye. It doesn't make that much sense. I mean, when there's not much orbital involvement. Of course, if there is orbital involvement and there is, even if the original cause of the no perception of light was a vascular cause and there is orbital involvement, then we would consider exenterating. But if there is no orbital involvement on imaging and there is and there is documented evidence that this is a vascular event rather than a invasive event, we would we would not exenterate in those cases.
Okay. Dr. Gaurav, the case, I think is Dr. Gaurav, the case where you showed that you went transcribriform and drained the abscess and did the reconstruction. We would like to know more about the patient. How is he doing currently?
He is doing fine, actually. We had 4 such cases where we had an initial intracranial involvement, and we actually did, remove all the abscess transnasally and then reconstructed it. The only thing that I usually do especially in these cases, is that whatever the tissue that I'm placing along the skull base, I make sure I dip it in gentamicin. And then if I'm inserting fat intracranially, then that has to be dipped in gentamicin, and then the overlay also as well. Out of these 4 patients, one of them progressed to develop an abscess which was about 5 centimeters big, which required an open approach to sort of drain and clear out. And even after that, he is doing pretty well so far. We always tell the patients and the parents as well to keep the prognosis. The prognosis is always going to be guarded in these sort of patients. But we also do a daily counseling for these patients and sort of reiterate the fact that they may not do well. And also the financial team separately talks to them with regards to the costing and whether or not they want to pull out or they want to continue. It is all up to them. But if the patient and their attenders are willing to fight, then we would want to help them do that.
What generally we have seen is once it goes intracranially, then the mortality is almost 50%.
Very high.
Yeah. It
It's
goes directly to 80%. So I had a patient like this, which transcribriform, he developed cerebritis, and then he had superadded infection. He went into septicemia, and then he eventually died. Any final thoughts before we close the session from each of you individual participants?
I think I have a question for Dr. Aisha, if I can.
Sure.
Being an infectious disease specialist, when do you think this is going to stop?
$1 million
That question comes to the infectious disease specialist at an alarming frequency on a daily basis. And I don't know why.
We're all looking forward to that day. It's not a really nice disease to treat, and either for the surgeon or for the ID specialist. No, it's not a really pleasant experience.
Yeah, but I think somewhere we have to accept to some extent that, of course, COVID is a predisposing factor, but to a large extent, this has been an iatrogenic outbreak. And it has been due to poor practices of treatment of COVID. And that's something that we all need to learn and take from.
Yeah, I think the polypharmacy bit, we also do a lot of, like all the antibiotics, patients who come in, they're all on doxycycline, they're on ivermectin, they're on azithromycin.
And a large number of them have co-infections, sort of bacterial co-infections, and we're often surprised to see how many of them have resistant bacterial infections because they've already received a host of antibiotics, when they first developed symptoms of sinusitis. So we've had carbapenem resistant infections in several patients, and it becomes very difficult when you're trying to use amphotericin B and other nephrotoxic agents like polymyxin,
I think we should reflect on, the medical community itself has reflect on the number of drugs we give patients on just empirical value, not on any clinical signs or just so many patients on lots of useless drugs which are very limited value in patients, and that could be somewhat contributing to the increased number of incidences in India itself, because a lot of the risk factors are all the same all over the world, but why India should have it, I think we should reflect on why it's happening. So I wouldn't put the blame solely on steroids. I think other antibiotics, all those things have to be had a second look on why we should prescribe them without, because we have seen patients who are on meropenem and piptaz and all those things, though they've had a very mild disease, they've had COVID disease has been very mild, they've not even had much symptoms, but they're all started on this high level antibiotics. We don't know for sure that this is the smoking gun, but that could be one of the factors.
Ethel, your thoughts? It's a helpless situation in spite of doing everything. You are kindly unmute yourself, Ethel.
I will not blame only to the wrong practices and use of steroids. It is something to do with the viral infection. Because when we have taken the history of our patients of the treatment of COVID, because it's a large volume of patients which are presented to us. So I don't think it's only steroid which has caused this. It is something to do with
the mutant strain,
infection per se, and the immunity. Because otherwise we are using steroid in so many other cases. 2 weeks, 3 weeks, steroid is used for so many illnesses. We don't see this kind of infection. So the mucormycosis is also multifactorial. It's not only because of I would not put it as an iatrogenic or not related to only treatment of mucormycosis, COVID. It is something to do with the immunity related to the infection.
Probably the mutant strain, the B161.
Something with the immunity of the patient. Because it is
basically
very
we
aggressive.
have evidence now that it replicates in the SARS-CoV-2 virus replicates in the pancreas cells, reducing insulin production, as well as there is apoptosis of the beta cells. So that probably this particular strain is increasing the hyperglycemia to such high levels that and along with microthrombi, all those things coming together, it's probably that is what is the crucial key step. All of course, all the other things may be contributing, maybe, but the main thing would be the COVID itself. COVID infection itself is causing this triggering of mucormycosis.
Finally, Gaurav, the way forward.
I think the way forward would be to correlate all this data that has come through and sort of create guidelines freshly so that we're ready for the third wave or fourth wave or whichever wave is going to come our way. As it is, India's now the healthcare system is, I wouldn't say it is collapsing. I would definitely not say that, because I think it's a huge applause to all of our colleagues, whichever stream of specialty they are in. I think they're doing a fantastic job. The problem is that patients who present post-COVID to us are already financially drained, and it's quite disheartening to tell them that that you may not be able to afford this. Government hospitals are doing the best that they can with the limited resources that they have, but ultimately there is going to be some spillover which comes through to our doors. I think we need to collate all this data, sit down and analyze as to what is the common factors that we're seeing in these patients, and sort of make a recommendation qualitatively. The time has come that we should not act independently, and we should all come together, give up our personal interests and bring this data out so that we can create a guideline for a better, healthier country as such.
Okay. So thank you, everyone. Thank you, Dr. Hetal, Dr. Aisha, Dr. Gaurav, Dr. Raghuraj, for spending such a long and marathon session, being there on a Sunday, away from your family, especially being busy with your own specialities. And also, I thank Alembic for putting this up, and hope it's beneficial and it's enlightened our audience, and hope we correct our mistakes. And as Gaurav said, we look forward to the right management, and we'll take it in the stride, whatever it comes. Thank you once again. Thanks. I hand it over to Charlie now.
Thank you, Dr. Ajay Doiphode, and the entire team of the eminent speakers that we had today. Thank you from Alembic, the makers of cloth, not only to the entire panel, but also to the attendees for making it a success. We look forward to you for more and more programs in the future. And that's how we plan to disseminate being committed to ENT as a fraternity. Thank you all. Have a nice day.
Yeah.
Thank you, Dr. Ajay, for giving us this opportunity.
Yeah. Thank
Thanks,
you.
Gaurav. Bye.
Thank you.
Bye,
Thank you,
Dr.
Dr. Ajay. Thank you, panelists.
Thank you.
Thank you.